Good afternoon, everyone. My name is Lance Christian, and I'm the Executive Director of the ALS Association Oregon and Southwest Washington chapter. I want to join you to our first broadcast this week for our ALS Research Week. Most years we have a live research symposium with multiple speakers from around the ALS community presenting research and data. Because of COVID and all the reasons you know, we've gone virtual this year. We're really excited to have 4 workshops this week, sort of lunch and learns that'll highlight aspects about new therapies as well as understanding the causes of ALS and the research being done to find treatments and cures. We'd like to thank our sponsors for helping to make this event and the services we support that we offer people living with ALS possible. In particular, the VC Fund, Providence Brain and Spine Institute, Fortis Construction, The Standard, Ability Center, and New Motion. Before I get started today, a few housekeeping items. Today's presentation will last for approximately 30 or 40 minutes with 20 minutes for question and answer. All participant videos and microphones are disabled to reduce interruption. If you have any questions for the presenter during the presentations, please type them into the Q&A box provided in the bottom of your Zoom control panel. Today's presentation will be recorded and made available for later viewing. And it's also being live streamed on Facebook for those who are unable to register. So without further ado, I'd like to welcome Dr. Paul Mehta and ask him to turn on his video and share his screen. So welcome, Paul. For many of you who haven't met him before, Dr. Paul Mehta is a medical epidemiologist and the principal investigator who provides oversight for the congressionally mandated National ALS Registry at the Agency for Toxic Substances and Disease Registries in Atlanta. Dr. Mehta and his team work closely with the ALS Association and advocacy groups, encouraging those to participate with living with ALS to participate in the registry. Dr. Mehta has been a guest here in Oregon before, and we're thrilled to have him back. So thank you, Paul, and welcome.
Thank you, Lance. Can you guys hear me okay?
Yes.
Great, excellent. Like I said, thank you so much for having us and for giving us the opportunity to go ahead and present on the National ALS Registry. I was there a few years back in Oregon. It's certainly a beautiful place. You know, like I like to say, you guys actually have real mountains in the West Coast compared to our hills here in the East Coast. So those Cascades and Mount Hood certainly is very, very beautiful. My name is Paul Mehta, and I'm the PI of the National ALS Registry. And today we'll be talking about what the registry does and how you can join the fight against ALS. I've got no disclosures. Just a quick outline of the presentation itself. We're talking about the importance of the National ALS Registry and why you should join. National ALS Bioposter, what is it and why is it important, and how you can join, and how you can join clinical trials and studies as well, and our risk factor surveys. We're also be talking about today about what we are doing to go ahead and find what causes ALS and looking at the risk factors for ALS, as well as reporting on who gets ALS. We also fund research, so we'll go ahead and talk about the research we fund and so forth. And at the end, we'll go ahead and answer any questions. So just very quickly, you know, we like to say the National ALS Registry does a lot more than just count ALS cases. So we have our biorepository where we go to patients' homes to go ahead and collect samples, which I'll mention momentarily. We do the epidemiology of ALS, where we look at the incidence, the prevalence, the mortality of ALS in the U.S. We work with partner organizations such as the ALS Association, which is one of our most important partners, and we work with all chapters across the country. We also collect survey data as well, so when someone joins the registry, they can go ahead and take risk factor surveys, and I'll mention those as well. We also have something called a research notification mechanism, where we go ahead and connect patients with clinical trials and epidemiological studies. And we also fund research. So why is the National ALS Registry important, and why should you join? So, you know, there are more unknowns than knowns about ALS, but scientists are certainly working very hard to figure out those unknowns about ALS. And the registry allows people to fight back and help defeat this disease by being counted. So some of the goals of the registry are, like I mentioned before, you know, what causes ALS, the etiology of ALS, the risk factors of ALS. So we know, for example, those who serve in the military have a higher risk of getting ALS. We're not sure why, but certainly we want to go ahead and examine why and what those risk factors are. We also want to look at the number of cases of ALS in the U.S. as well. So what we do here is we go ahead and collect and analyze data. We fund external research to academia. We also, like I mentioned, connect ALS patients with clinical trials and research studies. And we also collect biospecimens through the National ALS Biorepository. So how many cases of ALS are in the U.S.? So right now, just a quick background information, ALS is not a reportable disease in the U.S. And so what do I mean by that? So in the U.S., there's things which are reportable to public health departments, such as, let's say, COVID-19 or such as tuberculosis and so forth. So a lot of the communicable diseases are actually reported to health departments, and they in turn go ahead and report those over to CDC. And so you can certainly have a much more accurate case count when things are reportable. So with ALS is not reported to state health officials, with the exception of Massachusetts. And we also can't get data from private insurance companies because private insurance companies will not release to us exactly names of who they're actually taking care of. And so without that, we go ahead and use certain databases such as Medicare, the VA system, and our online portal to go ahead and collect those cases. We estimate we collect between 80 or 85% of all cases in the U.S., and the ones we're missing are certainly coming from places such as private insurance. But regardless, we all can agree one case of ALS is one too many. So how many cases are there in the U.S.? So right now we estimate there's almost 17,000 cases of ALS as of 2015. You're probably asking yourself, well, this is 2020. We're currently working on 2016, which will be published next year. So a lot of these data we actually get from Medicare as well as the VA, and they're about 2 or 3 years old. So once we get the data in-house, we'll go ahead and analyze them and go ahead and publish them and let them be available to everyone to read. So right now, there's about 5.2 cases of ALS per 100,000 in the U.S., which is a slight increase from 2014. We're not seeing the number of ALS patients necessarily increase in the U.S. That is the incidence getting more. What we're seeing is we're doing a better case of capturing these ALS cases. ALS continues to be more common in whites, males, and persons between the ages of 60 and 69. Males have a higher prevalence of ALS than females, and that's across all data sources, meaning to say the sources such as Medicare, as well as the VA system, as well as our own internal data as well. This is also consistent with other published studies as well. Like I mentioned before, we're currently working on the 2016 prevalence report, and that will be coming out next year. And with this report, it's going to be somewhat interesting and much more consequential. We'll be releasing two prevalence estimates based upon what we have, our algorithm currently, as well as what we're missing. So we'll actually release 2 numbers out for 2016, and the second number is going to be talking about what we're missing. So it will include an estimate of the number of cases that are in the private insurance, and we're doing that by using something called capture-recapture methodology. So switching to the risk factors we have, once a patient joins the registry, they can go ahead and take risk factor surveys. We currently have 17 risk factor surveys, which I'll go ahead and show you guys. But these surveys are really, really important to helping us solve the mysteries behind ALS. So we ask questions about where did you work? Certain occupations we know have a higher risk of ALS than others. Military service, why are veterans at a greater risk of getting ALS than non-veterans? Physical activity, smoking, drinking. We know some physical activity could be a risk factor for ALS. TBI, traumatic brain injuries, we know those certainly could be a risk factor for ALS as well as exposures to certain pesticides and chemicals as well. So we also ask questions about, did you ever use these sorts of chemicals, throughout your life? We also have something called disease progression, which is ALS FRS scoring. We'll go ahead and see if a patient is a fast progressor or a slow progressor. And this survey is taken when a patient first registers and then every 6 months. Then we also have a survey which allows you to tell us what you think may have caused your disease. So it's actually a qualitative survey where you can actually type in what you feel may have caused your disease itself. And these surveys, like I said, we have 17, soon to be 18. And the 18th survey we'll be releasing probably in about next 2 or 3 months. That survey actually is going to be looking at specific sports that people have played throughout, for example, in high school, in college, or even professionally. And we certainly appreciate the caregivers and family members who certainly can help patients take these surveys. These surveys can be taken in any order. There is no, there's no order as in terms of 1 through 17. You can take them whichever order you wish, and you can also take them at your leisure as well. This right here is our list of surveys, currently 17, soon to be 18. And as you can see with the bottom right-hand number right there, we have over 90,000 completed surveys. So this certainly is a very rich data source coming from patients directly and all their hard work taking these surveys. And so like I mentioned, just a few, but like I said, these surveys, we're asking a lot of questions about potential risk factors for ALS. We also publish this data as well. So whenever we have results, we'll go ahead and publish these data too. So switching gears to the National ALS Biorepository and why is that important? So the Biorepository helps researchers in the areas of genetics. So we know there's currently over 30 genes for ALS right now, with the most common ones being for SOD1 and C9orf72. But there are also other genes which have been identified as well. And so the Biorepository helps us look for these genes. It also helps us look for biomarker identification. So it helps us examine, for example, certain drugs, if they will work or not, as well as, right now there is no drug test for ALS. I'm sorry, there's no blood test for ALS. And without a blood test, it's very, very hard to catch ALS early. So our hope, and the hope of many researchers, is potentially to have that diagnostic test for ALS to catch it early on. So the Biorepository certainly helps in that research area right there. And we also look at areas such as heavy metals, exposures to lead, arsenic, and others, as well as something I mentioned previously, something called persistent organic pollutants, which kind of stay around the environment and they're very hard to break down. And these include PCBs, DDT, and certain insecticides and pesticides as well. And some more information on the Biorepository. So those surveys I showed to you earlier, all those surveys are actually linked and married with the patient's specimens themselves. So we have a rich information and data about patient, where they work, where they're in the military, and that's all connected with the patient's biospecimens as well. We also collect data not just at a certain location. We collect data across the country. It's also user-friendly, so we come to the patient's homes to go ahead and collect these samples. And so right now we've halted this collection of samples with COVID-19 only because we don't want to have any sort of potential exposures from our phlebotomists coming out to patients' homes for exposures. So right now we've suspended it momentarily until we can have a vaccine in the pipeline and approved and so forth. But certainly it's one of those things I would definitely encourage you to go ahead and complete the portion when you register for the Biorepository so we can mail you information about it. There is no charge for these for us to come to your home and get your blood or your saliva. No charge whatsoever. This is your Biorepository. This is your registry. So these so we come to your home at no cost to you to go ahead and collect your blood. We can also do saliva as well. So right now, because of COVID-19, we could certainly send you a saliva kit if you wish. And then as the pandemic subsides, we can certainly go ahead and collect blood later on as well. And so, like I mentioned before, the Biorepository is the largest collection of pristine ALS samples for research. And like I mentioned, the areas we're looking at are genetics, biomarkers, disease progression, and so forth. This right here is a quick schematic of the Biorepository itself, where you have the in-home collections of blood, urine, saliva, as well as a postmortem component, which is bone, brain, spinal cord, CSF, and muscle. And that all goes into the National ALS Biorepository. And from there, the risk factor surveys, which are completed by patients, are matched with the samples. And then those specimens, as well as the data, are sent to researchers. So switching gears to clinical trials and epidemiological studies, we know there's a lot of clinical trials currently out there for ALS, in the pipeline here and there. You may get more information about it, whether it's like in your Facebook feed or something like that, as well as just from hearing about it from your providers and your clinicians. So what we do is we work with drug companies to go ahead and help them with the recruitment for these clinical trials, as well as epidemiological studies for academia. So when a patient comes in to the registry at cdc.gov/ALS, they'll go ahead and click a box saying, I want more information about clinical trials, and we'll send them more information once a clinical trial is approved by our committee. Right now, we're probably sending out one new notification almost every week. So it's certainly a good time to get information about clinical trials and epidemiological studies. So far, over 50 institutions have actually used this system to go ahead and help them recruit for their scientific programs. So just to kind of highlight some of the notifications that we've helped to recruit for in the past. Brainstorm certainly has been in the news with their own mesenchymal stem cells. And I believe they'll be reporting more data within the next few months about this clinical trial, as well as Orphazyme as well. We helped to recruit for them, Orion Pharmaceuticals, as well as Amylyx Pharmaceuticals, which has certainly been in the news recently. There's been a number of articles written about it and how it, with the current data right now and the results, it appears to slow disease progression in patients, which is excellent. So AMX0035 is another drug we help to recruit for as well. So we also fund research. So switching gears, so research certainly is very important, and for us to go ahead and find out the unknowns about ALS, etiologies, risk factors. Like I mentioned, right now we have 19 research studies we've actually helped fund, and we're hoping to go ahead and fund more in FY20 as well. This past September we actually funded 2. And this right here, these are some of the areas we've actually funded. Are looking at something called cyanobacteria, or harmful algal blooms, which occurs in bodies of water. That certainly has been an important risk factor to evaluate this cyanobacteria. We're also looking at, like I mentioned, pesticides and pollutants, as well as in the air, as well air and water. We're also funding looking at biomarkers and genes. We're also funding looking at the role of hyperlipidemia and diabetes, as well as autoimmune diseases, and how that could be potentially a prognostic marker for ALS. We're looking at genetics, why certain populations have lower rates of ALS than others. So we're funding a study out of Ireland from Trinity College, Dr. Orla Hardiman, and she's a world-renowned neurologist, and she's looking at why the population of Latin America, specifically Cuba, Uruguay, and Chile, get ALS at a much lower rate than the European population of Ireland. So we're trying to figure out exactly why that population gets ALS at a lower rate than other populations. Military service and the risk for ALS, we're funding those areas as well as oxidative stress. So your body generates free radicals, and that certainly can lead to oxidative stress. And so we want to see that and how that intertwines with ALS as well. This right here is just a number of institutions we've actually helped to fund. So University of Michigan, Northwestern, Harvard, as well as Stanford's also not listed, but we've also funded them as well as Columbia. And like I said, I mean, it's very important for us to fund research, because research allows us to go ahead and work with these institutions to figure out causes and risk factors for ALS and how that could potentially translate into prevention down the road. So just a few more slides. So the impact of the National ALS Registry, we are the largest database of ALS patients in the U.S. And like I mentioned, this is your registry. We are here for you. We're here Monday through Friday to answer any questions you may have about signing up and getting registered. We work with drug companies and academia to go ahead and help them with their clinical trials and epidemiological studies. We also have the National ALS Bioposter, where we go ahead and collect samples for areas such as biomarkers, genetics, and so forth. We're funding research, and like I said before, research funding is so important for us to figure out the unknowns of ALS. And we're also figuring out the epidemiological trends of ALS, who gets ALS, number of new cases, number of existing cases, as well as who's actually passed away. So in essence, we're looking to solve the who, the what, and the why of ALS. So just quickly in conclusion, I'm happy to take your questions. We work with the ALS Association, which is our most important partner, and we all want the same thing. We all want to figure out, what causes this disease, and more importantly, we all want to have a cure for ALS. Thank you.
Thank you, Paul. If you can let go, unshare the screen. Thank you. Great. Thanks so much, Dr. Mehta. And just a little reminder for everyone, if you have a question, please type that question in the Q&A box, which is on the bottom of your Zoom screen. To kick things off, Dr. Mehta, you talked a little bit about some research studies that the registry is funding, but then also researchers accessing registry data. How many research studies have accessed the data over these many years, and are there some highlights of those, of who those studies are that you could share?
So we've actually helped to, so the data requests which come in, we've actually have probably over a dozen or more. This is also with just data itself as well as biospecimens too. And so those right here. So we've actually, like I said, probably it's been over a dozen. And some of the examples we've actually helped to give data out to researchers to analyze. One of them was for Duke, Rick Bedlack, who's looking at ALS reversals. And so we actually gave some of our data for that to go ahead and look at potential reversals of ALS. We've given our data to a number of big drug companies who are looking at both biospecimens as well as data as well. And some of those areas are looking at, for example, like I mentioned, biomarkers or genetics as well. So we are certainly, it's very important for us to go ahead and, push out our data as well as our biospecimens. We don't want them in our house or, in our freezers or on our servers. We want to make sure we go ahead and get the information to patients. And what we actually give to our researchers, we never give a patient's name or address or date of birth. It's always de-identified data, as we call it. It's always secure data, and this way no one's ever identifiable. And so we, like I said, whatever the information we collect, we want to go ahead and get out to researchers.
Great. One question that's come in through the question and answer box is, are you seeing clusters or pockets in the US where ALS appears to be more prevalent than in other areas?
So we get a number of, questions from the public or even health departments about certain areas where there could be an increased risk for ALS or increased number of cases for ALS. Now, there are no specific pockets that I'm aware of as in terms of let's say, for example, geographically, that there are increases. Like I said, we do get inquiries, but a lot of these inquiries are coming in from areas such as, for example, like there's a military population which is seeing increased cases in their, let's say in their group and so forth, or in their command structure. So we'll go ahead and provide them information and so forth. But there are no sorts of, I would say, specific areas where hotspots right now. But we are looking at data. We are working with partners to go ahead and analyze information such as this. Dartmouth actually has done some work on cyanobacteria, and they've seen some areas where there's been a potentially increased number of cases of cyanobacteria linked to bodies of water. But those are kind of like geographically in certain parts of the country. But as in terms of like a cluster of hotspots or areas, we're not certainly looking at that from our data itself, but the data which our partners have, they're actually seeing some areas of increased number of cases from, for example, whether it's Michigan or whether it's some parts of the Northeast, they're seeing that in their data sets, that is.
Has the registry itself done any sort of targeted research on urban areas versus rural or anything like that?
We actually did publish a paper a few years ago where we looked at patients and their proximities to their healthcare centers, the multiple disability centers, the MDCs. And what we actually found was almost half the patients live 50 miles or more to their closest center. So, and that certainly is much more important in areas such as the mountain states like Montana, Idaho, and the Dakotas, where it's a longer drive for patients to actually get to go ahead and to get to their the care they need. So we certainly know there is an area of need when it comes to patients accessing the care they have to have, and so forth. Regarding urban or suburban and so forth, we actually do look at that as in terms of our state metro areas. So a lot of our state metro projects we did in the past would look at certain areas of whether it's a state or a city, but those are trying to capture more of the more cases of patients who are in the minority area as well, and so forth. Because we know we are missing patients in the African American population, the Hispanic population, as well as the Asian population as well.
Okay, so it sounds like there's a lot more work to do.
Absolutely.
Yeah. Sort of similarly, this is a very local question. Do you receive a good percentage of people with ALS in Oregon taking part in the registry? You
guys do actually very, very well. You guys are actually an excellent chapter and an excellent location when it comes to informing your patients, educating them, and so forth. And so we provide data to you guys, as you guys are aware. internally about, what states are doing well and what states could actually they need some more help and so forth. But Oregon consistently ranks in the top 5.
Great. So follow-up question from a person living with ALS asking a question. If they want to participate, they haven't participated in the registry yet, and they want to, what steps would somebody take?
So first of all, you can go to our website, cdc.gov/ALS, and you can get more information about the registry and how to join. It takes about 5 minutes to probably go ahead and join, maybe 5 or 10 minutes. We ask you a series of questions about your ALS diagnosis, and from there, we'll go ahead and collect your information. It's done all securely. And then from there, you can opt in to get information about clinical trials or the biorepository. And then from there, you go to your dashboard to go ahead and take your risk factor surveys. And so for any clinical trials and studies that come around, we'll send you an email about them. And then our other team will go ahead and contact you about the biorepository. We'll actually mail you a packet about the biorepository and how you can join.
Great. There's a question someone's asked. Says, I'm fascinated by the increased risk in the military. Has this been looked at in more detail? How about men versus women in the military? Any sort of drill down on that population or data?
So we are actually funding a number of studies on that, looking at military history and so forth. Regarding women versus men in the military, there are more men than women in the military. So it is skewed towards more, towards more men. So, but we have not internally seen any sort of comparison in terms of women versus men who are getting ALS. From our data, it appears to be men are getting ALS at a much higher rate, whether you're in the military or even outside the military as well. But like I said, we are funding studies, 2 from Harvard right now. Mark Weiskopf is a professor at Harvard. He's actually looking at military history and ALS, as well as another researcher as well.
We have a participant asking, is research into the cause of ALS directly related to research into the cures, or are they separate processes?
That's actually a great question. I think it's really important for us to figure out what causes ALS and then concurrently work on potential therapies and cures for ALS as well. I think, this is certainly done, it's related, but they're kind of almost parallel as well, where you got one group who are, the pharma group, the ALS Association, who is certainly working with drug companies very closely to go ahead and, get those drugs approved by the FDA. And you got the other portion, like ourselves, which are looking at the research, the potential causes of ALS. If you can figure out what causes ALS and you can prevent ALS, that's certainly so important. Then this way you can kind of halt the disease and not, get to the portion where you actually get the disease itself. So, for our group, we're looking at, like I said, causes, etiologies, and so forth, while groups like drug companies and the ALS Association are certainly leading the efforts when it comes to therapeutics.
Great. You mentioned in your presentation that the next data set that you're going to be publishing is going to have sort of the hard count that you get from all the data sources that you tap into, the VA and Medicare and Medicaid, and then a sort of forecast or projection of what the private sector. Do you have any idea, or can you estimate and share what you think that portion of the population might be?
So we're still working on it right now. I can't give you any specifics, but I can tell you, we're going to have like a upper number and a lower number, and then there'll be like an average number of cases, which we feel are probably in the U.S. My guesstimate is there are probably between 20 and 25,000 cases of ALS in the U.S. And so between that number right there, whatever that number may be right there in the middle, but I'd say that's probably a very, very close estimate number of cases of in the cases of ALS in the U.S. when you include what we're not getting. We're not getting the cases from private pay insurance. So for example, a great example is you guys are in the West Coast of HMOs. I believe Kaiser's a huge group out there. We don't get a lot of their data. Data that we do get from insurance companies all de-identified. So there are sources of data that we can get, but it's not going to tell me, John Smith or whoever it is who I can connect to with my data as well. If I cannot have a identifier or a link, then I can potentially overcount the number of cases, right? So you have to make sure you go ahead and deduplicate those cases.
Yeah. Do you do any sort of meetings or comparison with other registries that may exist around the world in Europe or other countries?
We do have conversations. So, for example, in Ireland, I mentioned Dr. Orla Hardiman. She runs the Irish ALS Register, as they call it there. And so we've done some preliminary work with them to looking at the demographics of disease, what they're showing demographically, what we have as well. But we do also help other areas, for example, if they have assistance regarding potentially having their own registry or their own system to go ahead and capture cases. And we've actually helped out some countries there as well. But a lot of the countries in Europe, because they have certainly a single payer system of healthcare, they can capture all their cases much more efficiently than ourselves.
Mm-hmm. In terms of the data that you're collecting and people who are enrolling, sometimes there are many onset forms of diagnosis: motor neuron disease, primary muscular atrophy, PLS. How are those factored in terms of whose data comes into the registry? Does someone need a definite ALS diagnosis, or can it be sort of one of these onset diagnoses?
So my dog's barking, apologies. But no, it's we actually only look at ALS. Obviously, MNDs is a broader umbrella, and ALS factors into about, I think, 85% of MNDs, motor neuron diseases, are ALS. And then you got the PLS and so forth, and then some other ones as well. But we just currently go ahead and capture only ALS, and you have to be a case to go ahead and be in the registry.
Okay. So this is a question related to your clinical trials notification system. Some people with ALS have had ALS for many years, 4 or 5 years longer. Are there trials that you notify people about, or research opportunities for people who've had ALS for a longer period of time?
I'm sorry, could you repeat that question again? So
are there, in your research studies notifications for clinical trials and other ways to participate, if people have had ALS for many years, like 4 or 5 years, are there opportunities for people who've had ALS for a longer period of time?
Got it. So we actually don't set the eligibility criteria for the actual, let's say, drug trial itself. That's done by the drug company. But what we do is, I let them know, listen, your notification should go to all patients, and then they can kind of go ahead and decide if the patients want to go ahead and connect with the drug company themselves, and then they can get more information regarding eligibility. We do have a way to kind of go ahead and see when the patient was diagnosed, and we can stratify the data that way and go ahead and do a notification that way as well. But in general, my recommendation is to go ahead and get the largest pool of patients you can for a clinical trial or a study, and then have the researchers go ahead and screen them, accordingly. We both know this, Lance. I mean, when it comes to drug trials, there's always an issue when it comes for eligibility, and sometimes the patients can be excluded if they're on, let's say, Riluzole or some other medication, Edaravone, and Radicava. So, but the premise is, we don't certainly set those. I do understand the frustration some patients may have when it comes to not being eligible for a clinical trial or being excluded. That certainly is not a good thing. But like I said, I mean, there are many clinical trials out there these days, and more are coming down the pipeline. Massachusetts General Hospital, MGH, is working on something called the Platform ALS clinical trial, where they'll test a number of drugs at one time, I believe up to 4 or 5, and we'll be helping them to recruit for that particular platform trial as well. They're following the model of cancer, and certainly there are much more therapeutics for cancer than there are for ALS. And I think it's really important for us to get to that point where we have therapeutics and treatments for ALS, where we could potentially, whether it's reversing, or halting the drug, by itself. I'm sorry, halting disease by itself.
Yeah. Right now, I know you're gathering information with the assistance sometimes of caregivers directly about the person living with ALS. Has there been any thought about expanding the registry to include any of the history or information about family members of people with ALS?
So we do ask actually a question about that. It's their family history. It's one of the surveys we have where patients can tell us their history of not just ALS, but other neurological diseases such as Parkinson's or Alzheimer's. So we do have a subset in our surveys where patients can tell us about their history of whether it's ALS or other diseases that they may have, neurological diseases, that is. So that information is being captured.
Great. And just to follow up to that, I think there are some studies going on out in the world for sort of pre-familial ALS or people who have ALS in their families where family members can participate in some clinical trials. And we have information about that if anyone wants to contact us directly.
Great. And I believe there's also, which I'm sure, Lance, you're aware of, where places where people can go and get screening as well for familial ALS as well. And I believe there is no charge, or there's maybe a very, very small fee, but I believe typically there's no charge, and there are groups around the country which actually are doing that for patients as well.
Yeah. Looking ahead, what are you excited about in the years ahead for the ALS registry? What is it that you see on the horizon that's going to be the difference maker in this program?
Well, I think for us working with drug companies, funding research, figure out the unknowns of ALS, collecting our specimens and looking at areas of biomarkers, genetics certainly is very important, but circling back to how we are assisting drug companies when it comes to, with their clinical trials. I mean, as more potential therapeutics come out there, we stand ready to go ahead and help them out with their clinical trial assistance, recruitment assistance, that is. But fortunately, the arena of ALS is changing. I think the Ice Bucket Challenge a number of years ago certainly helped spur more attention to ALS. But being a researcher in ALS, more attention is always a good thing. You know what I'm saying? Because the more attention you get, the more awareness you raise. And this way, that awareness is so important to translate potentially into more research, which is coming not from CDC only, but let's say from the NIH or some other groups as well. The ALS Association is a big funder when it comes to doing research as well. So I think that certainly, is an important thing. We're kind of like Switzerland. We're like a mediator. We work with all parties when it comes to facilitating ALS research and collaborating with them. And I think it's a really, really small, tight-knit community, but it's a community which certainly is very committed and dedicated to finding out the causes, and getting treatments approved for ALS.
Great. Well, just sort of in closing, if you could share once again, if someone wants to participate in the ALS registry, how do they take that step?
So once again, you can come to our website, cdc.gov/ALS, and there's information about how to join. And you can also obviously work with Lance and his team as well at the Oregon chapter in Southwest Washington, sorry. So Oregon is one state and Southwest Washington is the other portion of it you guys get. So, and Lance and his team does a great job informing and educating and helping out patients to register. But, you can always give us a call too. And we have, like I said, our website, which has been redesigned to make it much more user-friendly. And from there, also I want to announce that the fact that, so in the past, patients who've actually registered, there's always been an issue with our password. Hey, our password expires, but now we've actually made it much more user-friendly. So a patient can come in, whether they're existing or a new patient, they can select the interval when their password will expire. So it could be 6 months, 1 year, or indefinitely. So you can click indefinitely, and that password is not going to expire. We just ask you to log back into your account once a year. This way to make sure your account does not go inactive. But that was certainly something that, patients were pushing, and we certainly listened to make sure we were user-friendly, to the patients. And we reached out to our IT team and said, listen, this is not going to work. We want to have our passwords to be more, more accommodating to our patients. And so patients, like I said, can go ahead and select 6 months, 1 year, or indefinite expiration.
Great. Well, as we know, the easier it is to participate, the more knowledge we can gather to share with researchers and give insight into the demographics of ALS. So it's very exciting.
Absolutely.
It's been amazing. I'll share in my experience of many years with the ALS Association to see the National ALS Registry from its launch to its growth in terms of adding the biorepository and becoming a research funder looking at some of these aspects. It's been a tremendous asset to our community, and it's always one of the high public policy research priorities for the ALS Association every year, working with the federal government and Congress to get continued funding for this program. As we know, nothing is guaranteed, and unless we advocate for it, there's no 100% surety that the funding will be there. And like any research program, I describe it's like a pipeline. If you don't put more water in, you can't push water out the other end of the pipe, which is the outcome which we all want, which is a greater understanding of ALS, and so that we can find new treatments and cures for this disease. So I want to thank Dr. Mehta for joining us today. And this is the first of 4 different research lunch and learns that we're doing this week. And thank you for joining us from Atlanta and the East Coast and sharing information about the National ALS Registry. We want to particularly also thank, again, our sponsors for this research series, the VC Fund, Providence Brain and Spine Institute, Fortis Construction, the Standard Ability Center, and New Motion. We hope you'll join us all again this week as we have some local and national research presenters. And so thank you all for your time and attention, and we'll see you in our next session. Thank you so much.
Thank you so much. You guys be safe. Thank you. Bye-bye.